over or underdiagnosis of cow's milk allergy? Is the CoMiSS awareness tool helpful? And we hope for an interactive discussion. I will briefly introduce the speakers. This is, in fact, the CoMiSS group, a group of friends and colleagues all interested in allergy and how to manage that best. And we meet regular, trying to improve our knowledge and approach for this problem. So the whole this symposium is in fact organized and on behalf of the whole expert consensus panel that you see on this photo. So the first speaker is Professor Carina Venter from Denver, Colorado. She's a dietitian. She's very well known. Wait a little bit. She has given already quite some talks at this meeting, and she will entertain you soon more. And then the second speaker, it's myself about CoMiSS, and the third speaker is Professor Sajewska from Poland, Warsaw. She's the head of the department, and I think she's also quite well known to this audience, and she has a major interest also in this topic. So in order to save time, you can also download the CoMiSS user guide and the CoMiSS tool. As I said, in order to save time and to leave a lot of time for an interactive, constructive discussion, I hope I give now the floor to Carina, who insisted on speaking standing.
Thank you. I think I talk better when I'm standing up, but thanks for the offer to sit. Okay, so I'm going to start the session talking about over and underdiagnosis of cow's milk allergy and how do we get it right. And here are my disclosures. And so the objectives of my talk today will be to talk about the prevalence of cow's milk allergy, pitfalls in diagnosis of cow's milk allergy, and then also the pitfalls relating to overdiagnosis and underdiagnosis. But I think, one of the things that we have to always remember is that cow's milk allergy is by far the most complex presentation of food allergy, particularly in early childhood. And I think that's why we have all these discussions, because when we have peanut allergy, it's pretty clear when a child eats peanut, they have symptoms within 2 hours. You can do a skin prick test or specific IgE to confirm the history. If needed, you can do a food challenge, which normally you can get done within 2 hours and just wait another hour, so the family is done in 3 hours. But when you get to cow's milk allergy, we have the IgE-mediated food allergy as peanut with the immediate type symptoms. But the vast majority of cow's milk allergy present under this umbrella of non-IgE-mediated food allergies. So we have the food protein-induced enterocolitis. I'm not going to go into detail. There's been many sessions about that in this meeting, which is, classically the acute vomiting 1 to 4 hours after ingestion. But even with that, when we wrote the International FPAAS guidelines, we have had hundreds of emails about whether it's 1 to 4 hours or 2 to 4 hours. So you can see all the complexities relating to cow's milk allergy. We have eosinophilic diseases, and I show that again later, but as much as it's easy, more or less, to diagnose EOE by doing an endoscopy, The endoscopy is not going to tell you that the EOE is driven by cow's milk or egg or wheat, and that is taking a process of elimination and reintroduction. We have proctocolitis, which is classically the blood in stool, and then the mild to moderate non-IgE mediated cow's milk allergy, which is milder forms of usually a combination of symptoms, which are all highlighted in the CoMiSS score, which you will hear about in the other two talks as well. So really the symptoms of cow's milk allergy, it can be IgE mediated, which is the skin, the GI tract, the respiratory tract. It's non-IgE mediated, which again is the skin and the GI symptom. And really when we look at the bottom row, we can see that we have chronic acute urticaria, never chronic urticaria relating to food allergy. So acute urticaria, acute angioedema, colicky or abdominal pain, diarrhea, we have the lungs, the symptoms relating to the lungs, we have anaphylaxis, and then atopic dermatitis, and in the GI symptoms, the gastroesophageal reflux disease, blood or mucus in the stool, and then also filtering growth in the more severe instances. And here particularly, I think the symptoms that can be highly debatable is the colicky abdominal pain, it is the atopic dermatitis, and then also perhaps at what point is reflux troublesome enough to be associated with cow's milk allergy. Particularly now in the United States, we have to repeat over and over that atopic dermatitis causes food allergy, and food allergy does not cause atopic dermatitis. But getting back to what Jonathan Hurricane said yesterday, we really have to listen to every family and take their concerns into account. We do know that there are some cases of atopic dermatitis where they do not improve on sufficient topical treatment. We take milk out of the diet and the atopic dermatitis get better. At that point, you're going to have the discussion with the family. Are we going to keep the milk out at the risk of perhaps developing IgE-mediated cow's milk allergy later on, or are they going to have the milk in the diet and think about more, I would like to say, potent topical treatment, or perhaps treatment which by injection, such as a Dupixent, which you've heard about many times in this meeting as well. So cow's milk allergy prevalence, it differs quite a lot worldwide. You can see that, in Singapore, and also obviously age-related. So just the fact that I've got no data there for the Philippines doesn't mean that there's no cow's milk allergy in the Philippines. We've recently had the Apache conference in Singapore, where clearly we discussed, cow's milk allergy in infants in the Philippines, but the only data we have looking at prevalence is in teenagers. We can see some numbers in Singapore, and then it gradually really increased looking at data from China, the third line down, the UK, and then also the United States, which is data from Ruchi Gupta, which I think she's presenting at this meeting as well later on. We also recently did a systematic review. I'm one of the co-authors looking at cow's milk allergy prevalence in Europe. We looked at 93 studies. We concluded that self-reported cow's milk allergy was 5.7%, and that the point prevalence of cow's milk allergy based on oral food challenge outcome was 0.3%. But this 0.3 was actually much higher when we also included children who had clear symptoms supported by specific IgE. So this number of 0.3 may be slightly higher. But I want to take you through my data from the Isle of Wight. And now these children are not children anymore. They were born in 2001. And so my babies are now 22 and having their own babies. But when they were my babies, we did challenges from 6 months of age to cow's milk. We actually did prolonged double-blind placebo-controlled food challenges at home. So they were given cow's milk formula mask, and also hypoallergenic formula mask to do these week-long challenges if they had delayed symptoms. I literally did drive those infant formulas all across the Isle of Wight. So I know that we've actually done this. I know in clinical practice it's not really possible, but it's interesting to look at the data that I'm going to show you. And so looking at this 969 children, let's round it off to 1,000 children born on the Isle of Wight, you can see that over 3 years of life, we only had 2 children with IgE-mediated cow's milk allergy, and the vast majority of the 26 was the mild to moderate non-IgE-mediated cow's milk allergy, and like I said, really proven with double-blind placebo-controlled food challenges. I want to take you also through this because we're talking here about over and under diagnosis. So at the time when my data was published, I had to leave the country and go to America for a week because I was all over the Daily Mail in that blue banner. Mothers are egging it all up or putting it on, or Dr. Venter says it's all in the mind, because we had 54% of parents reporting some sort of food-related adverse symptom. So that was about 487 of these. When we further discussed it with them, we excluded 177 that we thought on clinical presentation probably doesn't warrant any further assessment. Then we did some further assessments and questioning in the 310. And we did large numbers of oral food challenges, and like I said, prolonged double-blind placebo-controlled challenges. And eventually, out of the almost 500, we found that only 35 children had a positive open food challenge, which was 3.5%. And of the 35 who then agreed to undergo double-blind challenges following a positive open food challenge, only 20 of the challenges, just over 50%, were confirmed on double-blind placebo-controlled food challenges. But all the children with a negative double-blind challenge following a positive oral food challenge showed subjective symptoms, which once again showed that if you have an oral food challenge with subjective symptoms and you can do a double-blind challenge, it's probably better, as there may be some false positives. But for clinical practices, I think, if you at least can do the open oral food challenge to prove the symptoms, either for immediate or delayed symptoms, it really helps you to make a clear diagnosis. And so this brings me to the next slide. So just remember here, we had about 50 to 60% of children where the parents reported the child to have a food-related symptom. And then by the time we took them through the whole diagnostic process as allergists, pediatricians, gastroenterologists, and other healthcare professionals do, we ended up with around about 3%, 2.5% to 3% with challenge-proven food allergy. So this paper, it's highly, highly unfortunate that papers like this get published, because this paper was published in Clinical Experimental Allergy, and it actually shows that when you look at the list of symptoms that may be related to food allergies, such as listed in the IMAP guidelines and in the NICE guidelines, you're going to diagnose either 1 in 11 with severe non-IgE-mediated cow's milk allergy, or up to 75% of children with mild to moderate symptoms. So this 75%, is very similar to what I saw on the Isle of Wight. But no clinician is going to diagnose food allergy on the basis of a list of symptoms. As I've already showed you, you have the symptoms, then you do your clinical reasoning, and I'm going to go through that on the next slide as well, to finally end up with a clear diagnosis, opposed to just diagnosing a child with a food allergy based on a reaction. I mean, I can see there's many allergists here in the room, and if I brought a 6-month-old baby into your clinic today and say, this baby has a rash, would you say that's a peanut allergy without any further questioning or testing? No, because that's what we need to do. We have a baby with a rash. Babies have rashes for many, many different reasons other than food allergy. And so I wanted to highlight this. We should never stare ourselves blind at data like this, because all the food allergy guidelines, and Alex Santos have given some beautiful presentations at this meeting about the new EAACI guidelines on diagnosis of food allergy. We need to ask about symptoms. It's debatable whether family history of atopic disease play a role, but again, highly debated in the guidelines, and we finally included it. In terms of cow's milk allergy, you need to ask about intake, past intake, current intake symptoms, and whether the symptoms recurred. any other concerns with feeding difficulties or poor growth, any other changes in the diet, and then finally make a diagnosis and think about management. There are now many different cow's milk allergy symptom scores. So I've already mentioned Roseanne so many times today in my presentations, but she was also the lead author in this systematic review looking at cow's milk allergy symptom score. I think, the point I want to highlight with that is that there are many scores out there, but there's really only one that's been clearly validated, and you will hear more about the CoMiSS score in subsequent presentations. So the pitfalls in the diagnosis of non-IgE-mediated cow's milk allergy is, despite differences and sometimes overlapping manifestations between the different forms of particularly non-IgE-mediated food allergies, the diagnostic process is uniform and there is no test to diagnose the food allergy other than, based on the history of the clinical manifestations. In bold, you may want to take the food out for 2 to 4 weeks, but you absolutely have to reintroduce the food to make a clear diagnosis, and I hope I've showed that to you clearly from the Isle of Wight data. There's dangers of over or underdiagnosis or delayed diagnosis, such as faltering growth, micronutrient deficiencies, poor sleep, and feeding difficulties, because you're taking foods out and you don't know what is going on. So we really want to make sure that we have a timely, clear diagnosis. It can have detrimental impact on quality of life of the family, and it also affects the healthcare system, particularly relating to prescription of medication and alternative formulas. So clear and diagnosis is very important. There's also a danger of overdiagnosis. So this is a little bit of a boring slide, but the bottom line of this is also data from me on the Isle of Wight. So I compared children that was just avoiding foods because the parents thought they had a food allergy or the children thought they had a food allergy, versus children that had a clear diagnosis of food allergy. And so if you look at the overdiagnosis group, I would call them, so the group that just took it out because they thought they had an allergy, but there wasn't a true allergy, there was no significant difference between the true allergies and those that just avoided the food in terms of all the different domains of quality of life. So clearly overdiagnosis and unnecessary avoidance is going to negatively impact family quality of life. And then my last 2 slides is cow's milk allergy has short-term avoidance implications because the diet is less diverse, they have a limited number of food intake, so important not to take a food out unless you're clearly allergic to it. And it also has long-term implications. These are children from our Isle of Wight study where they had avoided milk in the first year of life, outgrew their allergy. We looked at them at 10 years of age. So 9 years after they've outgrown their milk allergy, they were still more reluctant to consume dairy products, dairy substitute products, and eat chocolates, which, thinking about my immunonutrition talk, it's probably not the worst thing, but they still had less diet diversity and reluctance of having a normal diet. And so with that, really, I would like to conclude to say that cow's milk allergy is one of the most common and complex allergies of early childhood. The diagnosis of cow's milk allergy is challenging, particularly for non-IgE-mediated cow's milk allergy, but both under and overdiagnosis have consequences, and we have to do right by the families we see. Thank you for your time.
Speaker, the Q&A session will be at the end for all the talks, and I remind the audience who joined us online there is an option to ask questions. And in the meantime, Professor Ivan van den Plas is already ready for presentation. He was already saw his CV, so he is a leading person for CoMiSS, but I would also like to mention that he is the first author of the ESPEGAN position paper on cow's milk allergy, which is already online in Journal of Pediatric Gastroenterology and Nutrition, and I hope it will be very soon in the printed version as well. Ivan, the floor is yours, and you will talk about what is the role of CoMiSS in preventing over- and underdiagnosis.
Thank you, Hanya, for the nice introduction. So I would like to add one word to this title. what's the role in CoMiSS in trying to prevent over and underdiagnosis, because that's what it's all about, and we certainly do not claim that CoMiSS is the final answer to avoid over and underdiagnosis. So you heard in the nice talk of Karina that the prevalence of cow's milk allergy is still a challenge to know how many infants indeed do suffer cow's milk allergy. If you look in general in literature, it's somehow between 0.5 to 3%, depending on the definitions used. And if you look at the Europreval study, which is challenge-proven cow's milk allergy, in Europe it was 0.6%, but as pointed out, that needs an oral food challenge, which means in daily practice a lot of parents refuse that oral food challenge. And these children are considered then as non-allergic. While if you do not apply a food challenge, of course, you risk to overdiagnose. But as also said already, most children outgrow their allergy to milk in early childhood, especially in the non-IgE mediated allergy. So again, from another paper, if you look worldwide, what is reported, oral food challenge confirmed cow's milk allergy 0.3 according to Karina's data, 0.6 around according to Europreval. If you look at other papers, it's between 1.9 and 4.9%, and there are even figures that you can find in literature, and I'm not saying that that is the truth, but pointing out that in some developed countries, even prevalences of 10% are reported. It's just about criteria for definition, what you considered as cow's milk allergy, and so it's everything between 0.3 and 10%, what you find in literature. As Karina said also already, you have IgE and non-IgE mediated allergy with all these symptoms, and this is just another way to present those symptoms. If you look at the prevalence of organ symptoms in children with cow's milk allergy, digestive, it's around 60%, respiratory tract 30%, skin manifestations about 70%, general manifestations such as crying and distress, 50% of all the infants. That means together 210%, which means that the vast majority of the infants present with a combination of different organ systems. And non-IgE mediated allergy, according to the paper referred here to, only less than 1% of the infants with non-IgE mediated cow's milk allergy present with one single symptom. So it's a question of combination of symptoms. Diagnosis of IgE-mediated allergy, you also already heard that. That's relatively simple because of the clear time interval, and you have specific rust and skin prick tests to make you more easily feeling confirmation that this child may have cow's milk allergy, although also in these cases you still need the oral food challenge to make the final diagnosis. The real challenge is in non-IgE mediated allergy, where again, according to the Europreval study, around 25% of the infants had non-IgE mediated allergy, and that's probably an underestimation because in the Europreval study in some of the countries the prevalence of non-IgE mediated allergy was 0%, which is very likely to be an underestimation of the reality. But so there is no laboratory test that helps you to think about cow's milk allergy like in IgE-mediated allergy. In order to increase awareness about the possibility of that diagnosis, there are questionnaires available online, which are often used by parents because parents are going online. They use Dr. Google and try to come up with themselves a diagnosis. The problem with that is that they are available, but they are not validated, and they are therefore also not really evidence-based. So with that in mind, with this group of co-authors that you saw at the introduction on the photo, we developed the CoMiSS scores, which is the cow's milk symptom-related symptom score. So it's positioned as an awareness tool to help healthcare professionals to think about the possibility of cow's milk allergy before that child that presents with a mixture of different mild to moderate symptoms. And up to now, there are not 25, but 26 studies, original randomized controlled trials, which have used CoMiSS. So what are the symptoms that are scored? It's gastrointestinal tract in general, so regurgitation and crying, and according to the severity, there is a score from 0 to 6. Stools are also scored with, and we original CoMiSS score, the Bristol stool scale was used, but then later the Brussels infant and toddler stool scale was developed because, of course, stools of non-toilet trained children which wear diapers look totally different than the images of the Bristol stool scale, and so what we could do is switch from Bristol stool scale to the BITS without changing the outcome of CoMiSS, and so also the stool consistency gets a scoring. And then you have the skin manifestations, including atopic eczema with, I would call it, a simplified scored score, and then also urticaria and angioedema will get a scoring. And finally, respiratory symptoms are also included. It has been a lot of debate to include them or not, because we are, of course, especially talking about infants, and whenever infants do have respiratory symptoms, it's of course most of the time related to infections. And we see for each of those symptoms that they have to persist for a certain period of time, and that there has been no arguments for infectious disease, so no fever, etc. So that ends up with a score going from 0 to 33 as a maximum score, and the interpretation of the total score is then that a total score of less than 6 makes, according to the available literature and evidence, that the symptoms are not likely to be related to cow's milk allergy, while a score of 10 and more may be suggestive of cow's milk-related symptoms and could potentially be cow's milk allergy. So the CoMiSS scoring form is not intended to be used as a diagnostic tool and should certainly not replace the oral food challenge. So cow's milk allergy diagnosis should be confirmed by a 2 to 4 weeks elimination diet, followed by that oral food challenge. As Hanya said, we just published within ESGAN a new position paper about diagnosis, management, and prevention of cow's milk allergy. And we say there as one of the statements that the baseline CoMiSS-related symptom score and its reduction during an elimination diet may be indicative for cow's milk allergy, but is not diagnostic. And then the question is, of course, by increasing awareness, do you favor overdiagnosis, yes or not, that's open for debate. So by increasing awareness, it may favor overdiagnosis, but on the other side, in order to have a score of 10 or more, you need maximal symptoms in at least 2 organ systems. And which means that an infant which only cries a lot, or only has constipation, or only has diarrhea, or is not considered as having cow's milk allergy, because your score will be maximum 6, which is then not suggesting cow's milk allergy. So it avoids that all those children presenting with one single manifestation are considered as possibly having cow's milk allergy and put on elimination diet. So in that way, depending on healthcare professional, it may also decrease the diagnosis, because in Belgium, every crying baby is put by healthcare practitioners on extensive hydrolysates, which is certainly something to be avoided. And as this slide shows you, from data from the UK, by increasing the awareness, the black line, you increase the prescription rate of hydrolysates. But at the same time, the dotted lines, you decrease the prescription of medication, which most of the time is also not useful, is useless, and has adverse effect. So increasing awareness means indeed increased prescription rate of hydrolysate, but at the same time in combination with a decrease of inappropriate prescription of medication. These data from China nicely illustrate that by putting children on a diagnostic elimination diet, you decrease the CoMiSS score both for eczema and urticaria, the respiratory score, and the CoMiSS score overall shows you a nice significant decrease in those children, especially with cow's milk allergy. So CoMiSS cannot be considered as a standalone cow's milk allergy diagnostic tool, but that is useful as an awareness tool for cow's milk allergy as well as for monitoring symptom improvement. And a decrease of CoMiSS score during that cow's milk elimination diet is predictive of seeing an reaction to the oral food challenge. So as I said, we recently updated the CoMiSS tool. Initially, just by consensus, the cutoff was put at 12 or more, but then as more and more studies were performed and the literature was reanalyzed, we changed the cutoff from 12 or more to 10 or more, and a lower score was according to the available evidence from the 25 trials, not indicating to be cow's milk allergy related. So the diagnosis of cow's milk allergy remains elimination diet for 1 to 4 weeks, followed by reintroduction in breastfeeding and challenge in formula feeding as a must to confirm the diagnosis. So again, from our consensus paper or our position paper, in clinical practice, the open oral food challenge is clinically more feasible and practical than the double-blind placebo-controlled food challenge and is sufficient to confirm the diagnosis of cow's milk allergy and the development of oral tolerance. And in IgE-mediated cow's milk allergy, the oral food challenge should be supervised by trained medical healthcare professionals. So the diagnosis remains oral food challenge. Summary, cow's milk allergy is a complex disease, difficult to diagnose. Its reported prevalence ranges somewhere between 0.5 and 3%. Most of the children outgrow milk allergy in early childhood, certainly the non-IgE mediated allergy In the Europreval study, all the children with non-IgE mediated allergy were tolerant to cow's milk at the age of 1 year. IgE is usually rapid in onset and relatively easy to diagnose with tools available to support the diagnosis, while non-IgE mediated allergy can be delayed and dose-dependent and is difficult to diagnose with lack of supportive tools. So consequently, awareness of the symptoms is not always known, with cow's milk allergy being misdiagnosed both over and under, having consequences for children, as Karina just showed you. So the CoMiSS tool was designed to support the diagnosis of the probability of cow's milk allergy and to raise awareness among healthcare professionals. It was a recent update, and it's a simple, easy, fast, non-invasive awareness tool. It takes 2-3 minutes to fill it in, and it's used to support the diagnosis of cow's milk allergy. But again, it is not a diagnostic tool, but it can be an effective tool to support the healthcare professional in avoiding under or over diagnosis of cow's milk allergy. Thank you for your attention.
Thank you, Ivan, very much. Thank you.
And then I give the floor to Professor Sajewska, who will talk you about CoMiSS in healthy children.
Okay, thanks a lot. Thank you very much. I will just open my presentation. Perfect. Okay, so it's a pleasure for me to talk at this nice meeting organized by Nestlé Health Science. This is the old information, and Professor Renan Shamir, who unfortunately for situation in the Middle East was not able to join us, but I know that he's joining us online. So all the best to him. And I will talk, here are my disclosures. And I will talk about CoMiSS data in presumed healthy infants. How does this strengthen our clinical practice? Where we are at the EAACI meeting, and this morning, Alexandra Santos presenting EAACI guidelines on the diagnosis of IgE-mediated food allergy with impressive 63 co-authors. I know, Karina, that you are one of the co-authors. Very impressive. But this quote comes from the editorial, which was also wrote by Alexandra. Infants and young children are particularly vulnerable from a nutritional standpoint, and so it's vital to ensure that a robust diagnosis is made in a timely manner to mitigate any effects on growth and avoid the development of aversive eating behaviors. A robust diagnosis. Many of you, if not most of you, are allergists, so probably you are already seeing pre-selected group of patients. But it's very important that those who are referred to allergists are really well selected. You already heard about CoMiSS and the 2022 update. We know that recognizing any kind of allergy is challenging, but especially recognizing non-IgE-mediated cow's milk allergy in infants is challenging. The CoMiSS is a tool to raise awareness of symptoms related to cow's milk, and CoMiSS values are already available for both healthy and symptomatic infants aged 0 to 6 months. What is not known are the data for CoMiSS, and they are still needed in presumed healthy infants between 6 and 12 months old. And therefore, within the CoMiSS, we started the project, and the objective of this study project was to determine CoMiSS values in presumed healthy infants who have completed 6 months and are up to 12 months. And those in patients within age range when the diagnosis of cow's milk allergy is often established. You have already seen the CoMiSS study group because Ivan van den Plasker already introduced the group, and together with some collaborators, and we were working on this project, and my young colleague from our department, Mateusz Jankiewicz, is the first author in this project of the manuscript, which is now under, I would say, the final stages of the review in a European Journal of Pediatrics, in the final stages, because just yesterday I got a message from the editors that it's only minor revision, and really minor. So we have done a cross-sectional study. It was international multi-center study. Participants were presumed healthy infants aged 6 to 12 months attending well-child clinics. Exclusion criteria included preterm delivery, acute or chronic disease, therapeutic formula, the use of therapeutic formula, the use of dietary supplements, or the use of any kind of medication. And the CoMiSS healthcare professionals were asked to fill in the questionnaires, and interviews were, of course, conducted in native languages. Here you see that in total we included over 600 European infants. They came from Poland, Spain, Italy, Bulgaria, Czech Republic, and Belgium. And on this slide, I am showing you the data median, 5th percentile, 25th, 75th, and 95th percentile of CoMiSS in healthy European infants aged 6 to 12 months. And as you can see, the median was 3, which is in line with what we saw in younger population up to 6 months. Here you see that the median was, CoMiSS was highest at 6 months, it was 4, and lowest at 12 months, which was 1. So it was declining, which is opposite to what we saw in younger children, when it was increasing. On this slide, you will see there was significant difference across age groups, in particular between infants 6 months versus 10 months, and infants 6 months versus 12 months. We also looked at the effect of gender and feeding type, and there were no differences across group based on gender or feeding type. And of course, we also looked at individual symptoms, and there were no differences for age, for crying, in the case of crying, for age, gender, and feeding. For regurgitation, it was no significant difference for gender or feeding, but there was for age. The same was for stools and for skin symptoms and for respiratory symptoms. There were no significant difference. I'm sure many of you are familiar with this film, which I like very much. Some like it hot. And the famous sentence, "Nobody is perfect." It also applies to studies. There is no ideal study. Every single study has some limitations, including our study. And here I summarize the major limitations. So first of all, we used convenience sampling, which was used for pragmatic reasons. So participants were selected based on ease of recruitment. And of course, random sampling would reduce selection bias. This was a cross-sectional study design, and of course, this type of study design is subject to non-response bias. There might be potential differences between contributing and non-contributing infants. And the representativeness of a healthy infant population, maybe there are 4 questions. And last but not least, there was uneven cohort study. There was discrepancy in the size of cohorts from different countries. 47% of participants were from Poland. One explanation might be that this very young, my very young colleague was very eager to include as many subjects as possible. But anyway, conclusions were from this study, from this cross-sectional study, that this study provides CoMiSS values for presumed healthy European infants aged 6 to 12 months, extending our understanding beyond the commonly studied age group, which is 0 to 6 months. And of course, further research is needed to assess the use of CoMiSS as an awareness tool for cow's milk-related symptoms for symptomatic infants older than 6 months. So what is next? Of course, we do have some plans, and one of them is to determine CoMiSS values in infants aged 6 to 12 months with symptoms suggestive cow's milk allergy or functional gastrointestinal disorders, something that we have done also in younger population. We plan to have this cross-sectional multi-center study with infants aged 6 to 12 months with symptoms suggestive of cow's milk-related issues. Of course, we will think about exclusion criteria, and as previously, the CoMiSS will be filled out by health professionals. So I did summarize you what is really new now, so new data when it comes to 6 to 12 months. And you have listened to my colleagues, and especially to Professor Ivan van den Plas, who are telling more details about CoMiSS. But every now and then, when I'm talking about CoMiSS, I have these questions. Are awareness tools for allergic diseases needed at all? And I know that some of you may ask this question yourself, and I did try to answer myself, and I hope it will be the start for some discussions that we can have later on. Well, why they may not be needed, and I was thinking about at least 3 reasons. First of all, risk of misdiagnosis and reliance on self-diagnosis. It was already presented here and many other meetings that there is a difference between self-reported food allergy and what is confirmed. So this might be one of the things that we have to think about. It may induce anxiety. Overemphasis on allergy symptoms may cause unnecessary concern. And the final one, medicalization of normal symptoms. I do remember that one of the reviewers, I think, Ivan, it was when we were on our Espegan cow's milk allergy, one of the reviewers said not every person who is sad has a depression, and not every child who is crying has some kind of disease. And I think it's really important that making people too aware might cause them to seek medical treatment for normal reactions or minor issues. So these are some of the thoughts why this kind of tools may not be needed. But there are also reasons why awareness tools are needed. And here there were first one, awareness and education. I mean, it really helps the public to understand symptoms, aiding early diagnosis, which is so important. Overlaps with other conditions. We have already heard, and you have also heard from Karina on this famous paper which was published some time ago, but allergy symptoms indeed often mimic those of other diseases, and it's really important to understand what kind of disease we deal with, or maybe we deal with healthy children, which will be equally important. And finally, it really, in my opinion, contributes to efficient consultations, because when patients are more informed, they can communicate their symptoms and concerns more effectively. When primary healthcare professionals are better informed, they will refer the patients in much more, I would say, reasonable way and save time and probably also money. So a compromise approach and balanced approach is a user education, I would say, for optimal health management, integrating the awareness tool with established diagnostic procedures ensures a robust approach. And this brings me to almost final part of my presentation, and again to the Espegan paper, position paper. With the first paper, there was 67, I think, co-authors. Here we have 73 statements. I wish we could present this paper here, but I will not present the whole paper. And again, Professor Ivan van den Plas is one of the co-authors, and Professor Renan Shamir, who was supposed to be with us, is also one of the co-authors of this paper. And I will just show you the statement from our Espegan document, statement on awareness and management tools. The baseline CoMiSS and its reduction during elimination diet may be indicative of cow's milk allergy, but is not a diagnostic. And this is a key take-home message from our presentation. And my final slide is, if you have any questions, please keep it for yourself. I'm not Google or ChatGPT. And I thank you very much for your attention. And of course, this was a joke. Thank you very much.
Thank you very much. Who has a question? Don't keep it for yourself. Is there a microphone? It's coming.
Thank you very much. This is a topic from my heart because I've spent the last 20 years working in this field in the community. I'm a paediatric dietitian. It's interesting to see that you have respiratory symptoms on your CoMiSS tool because we've published a study this year reporting symptoms. We did a service evaluation comparison and we found about 25% or so of infants did have respiratory symptoms, but mostly rhino congestion rather than runny noses and chestiness. And I noticed that's not included as one of the symptoms, but actually that was the key thing that we found in our cohort. The other thing about constipation, and it's good to see constipation mentioned on your tool as well, because often that's missed out too, but it's about soft stool constipation and the straining that these infants have rather than what most of us would think about as constipation. And again, we need this understanding, and I think one of the things about the tool and raising awareness is that we need to ensure that all healthcare professionals have lots of first-line management skills to offer to support all the EFGID symptoms, which are so common, your reflux, your constipation, your colic, and have that as your baseline, because as you talk about all these inappropriate prescribing of medications and things, and a lot of first-line knowledge will go a long way to avoiding overdiagnosis of cow's milk allergy, but recognising when it might be. So I think the tool has a lot of values, but there needs to be a lot of skills and knowledge amongst the professionals to use it effectively. But thank you.
Hey, Lisa, so I don't think you asked a question, but you have years of experience in this field and you made really valid points. And it's a difficult balance between over and under diagnosis, which I think all of us have highlighted, but points well taken. Thank you.
Other questions? Yeah.
Sorry, I'm clearly a bad allergy patient because can you hear my allergic rhinitis is beginning to give me hassle here. But one of the things that was highlighted in the immunonutrition session this morning is really that important collaboration between the dietitian and the allergist, gastroenterologist or pediatrician. And I think for no other food allergy, more so than cow's milk allergy, is that extremely important because of the huge nutritional impact it has taking cow milk out of a young child, particularly in infant's diet. So that's perhaps something that we haven't highlighted so far today, and perhaps that's something we can add to the CoMiSS score, is to say that if you are going to go through this diagnostic process, make sure you have a dietitian involved. Because particularly in the United Kingdom, we have highly, highly skilled dietitians in this field, such as Lisa.
I cannot see any other questions, also not online. But Ivan, I have a question for you. Can CoMiSS be used for like an awareness tool for cow's milk allergy or also for other food allergies?
Well, then it needs to be studied and validated for other food allergies. Up to now, it's only being tested in suspicion of cow's milk allergy. I think if you want to use it in suspicion of other food allergies, maybe yes, But again, that needs to be tested.
So you create our new projects.
Maybe.
Yeah. Karina, do you want to comment? No. You do agree. Okay. Okay. Any other? Well, but can you just comment, Ivan, because you are the father of CoMiSS, so probably that's a question for you. Can the CoMiSS be used to assess the severity of cow's milk allergy? To assess the severity of cow's milk allergy.
Again, a double answer, yes and no, because the higher the score, of course, the more the predominant the symptoms are. It's definitely that an infant with a score of 27 will suffer much more than an infant with a score of 11. On the other side, we voluntarily did not include some of the most severe symptoms, such as anaphylaxis or food protein-induced enterocolitis syndrome symptoms are not included. Blood in the stools is voluntarily not included because we thought that in case of anaphylaxis, action is needed and not losing time in filling in a score. And in case of blood in the stools, it's such a broad differential diagnosis that you should look at how the child looks like, because it could as well be severe sepsis as cow's milk allergy. And so we wanted to avoid that in case of severe manifestations, the healthcare professional would just fill in a score and say, well, this fits very well with cow's milk allergy, and not think about other very important differential diagnoses.
Okay, any questions from the audience or online? If not, oh, yes, okay.
Hello, good afternoon. I'm an allergist at a pediatric hospital here in Lisbon. I would like to ask you a more practical question about non-IG mediated cow milk allergy, because when you have a crying baby that cries a lot, has reflux, and the parents tell us, I think it's from the milk, and you take off the milk and the baby gets really better. So you say we should reintroduce 2 to 4 weeks later, but how do you convince the parents that now the baby is very well? How do you reintroduce?
There's many answers to that. So I normally say to the parents beforehand that based on the data I just showed you, in about 50% of cases, baby's going to get better on avoidance, but if we put it back, the symptoms won't recur. I don't have an answer for that, whether it just means the baby's digestive system is getting better at dealing with foods or infant formula or breast milk. That may be an answer. There's some people that say they literally sign a contract with the family that they agree that they will reintroduce the food. But look, at the end of the day, we are working with human beings. We're not doing mouse model experiments. And if the family just refuses, there's nothing you can do. What I do then in that case is, rather than perhaps a 3 or 6 months follow-up, I try and book a 1-month follow-up and see if at that point we can have the discussion again. But I can tell you that I've had parents who said to me, yes, we will of course put the cow's milk back, but you're going to clean the carpet, you're going to do all our washing, and you're sitting up with the baby at night because we're not going back. So I think it is really just that discussion with the family, but we cannot force people. But in that case, I definitely, like I said, I reduce follow-up time to see how soon I can at least try. The other thing as well as, and this is not really part of CoMiSS, and it's not none of the guidelines, but clinically, perhaps I can get them to do the milk ladder. Now, we've clearly said in IMAP, the milk ladder is for a year later when we try and see if tolerance have developed. But if I cannot get them to at least do that initial reintroduction after 2 to 4 weeks, but they're willing to consider the latter, I will actually start doing it at that point.
Okay, thank you very much.
Thank you very much. And with this introduction of the milk ladder, we will end this session because time is over, and I would like to thank you all for being here and for the questions. And I would like to thank Nestlé Health Science, of course, for making this possible and supporting this event.